Hi, I am Evelyn Breville. My presentation today is going to be about rubella. Rubella is also known as German measles or Three-day measles. It is caused by the rubella virus, which is a member of the Toga virus family and genus Rubivirus. Typically, it occurred during in the spring, and humans are the only reservoir. The incubation period is usually about 2 to 3 weeks. Rubella is transmitted by direct person-to-person contact and transmitted by airborne droplets from the respiratory secretions of an infected individual and is contagious from a week before and a week after the disease. Pregnant women also transmit the infection to the fetus, which is called vertical transmission. And fetal infections rate are high as 81% during the first trimester, 25% during the late second trimester, and 35% from 27 to 30 weeks, and nearly 100% for fetus exposed beyond 36 weeks. Since the introduction of rubella vaccine in 1969, rubella cases have been declining. It has been reported only 58 cases per 100,000 populations in 1969, 0.45 per 100,000 in 1990, 0.1 for 100,000 in 1999, and in 2015, rubella has been declared eliminated in the US. Globally, 100,000 babies are born with congenital rubella syndrome each year. And during the pandemic in the US, that was in 1964, they had 12.5 million cases. And from 2005 until 2011, in the US, they had only 11 cases each year, which out of them, 42% cases were from women immigrated from other countries. For the first 5 months of 2019, they had only 971 cases of measles in the United States. Complications from rubella infection can include polyarthritis, which can manifest about 1 week after the rash, tensinovitis and carpal tunnel syndrome, thrombocytopenia associated with purpura and or hemorrhage, post-infectious encephalitis, myocarditis, pericarditis, hepatitis, hemolytic anemia, and hemolytic uremic syndrome. The mortality rate in the US from 1985 to 1992 was estimated to be at 0.2%. More than 300 children die every day from measles worldwide, and about 140,000 people died from measles. That was in 2018, and out of them, more deaths were among children under 5 years old. About 50% of rubella infection cases in pregnancy are asymptomatic. The pregnant woman is at risk for spontaneous abortion, preterm birth, stillbirth, and low birth weight. The fetus is at risk for fetal infection, fetal death, low birth weight, stillbirth, intrauterine growth restriction, cardiac anomalies, hepatosplenomegaly. Fetuses exposed to rubella during the first 16 weeks of pregnancy are at risk for congenital rubella syndrome, CRS, and the most common manifestations of CRS are hearing impairment, cataracts, eye defects, cardiac anomaly, hepatosplenomegaly, and later on the child may develop intellectual disabilities, autism, progressive encephalopathy, and diabetes. Subjective presentations of rubella may include low-grade fever, the 3 C's, conjunctivitis, coryza, cough, headache and malaise, sore throat, and polyarthralgia. These symptoms may last about 1 to 5 days, and the objective presentation may include lymphadenopathy in the post-auricular, which may last about 3 days, deep cervical lymph node, suboccipital lymph nodes, and at the end, macropapular pink rash that begins on the face and spread to the trunk and then the extremities. And the rash may last about 1 to 3 days. Rubella is associated with any viral or bacterial infection diseases with exanthem, such as scarlet fever, roseola, parvovirus, enterovirus, mononucleosis infectious, toxoplasmosis, and drug reactions. Diagnosis tests. Polymerase chain reaction analysis can be run to test specimen from nasal and throat swab, blood specimen, urine, and cerebrospinal fluid specimen. However, the EIA is the preferred initial test for serology. If the IgG is positive and the IgM is negative, the individual probably is immune to rubella. If IgG and IgM are negative, it is recommended to repeat the test in 3 to 4 weeks from the time of exposure. A fourfold rise of IgG titer is seen between acute and convalescent serum specimen. IgM positive with low avidity and a rise in IgG, it represents acute infection. And if IgG and IgM are both positive with high avidity, it might be a false positive or reinfection. Polymerase chain reaction analysis can be used to identify in utero fetal infection by performing either a chorionic villus sampling, a fetal blood sampling, or from the amniotic fluid. In case of congenital rubella syndrome, consultation and counseling should help the woman in deciding whether to continue or terminate the pregnancy. And for those who decide to continue the pregnancy, immune globulin can be offered, not to mention that its effectiveness in preventing transmission to the fetus is unknown. Supportive care and symptom relief is the mainstay of rubella management. The patient can be offered with acetaminophen for pain and fever, and glucocorticoids and platelet transfusion are really reserved for severe cases of thrombocytopenia and or encephalopathy. Usually the prognosis in pregnancy is excellent. Who can get vaccinated? All children between 12 to 15 months and 4 to 6 years old should receive rubella vaccine in conjunction with measles and mumps, MMR. All adults born after 1967, all postpartum non-immune mothers, and it is recommended to rescreen for rubella immunity 3 months after vaccinations. And what are the contraindications? Pregnancy, and if any women who are planning on conceiving within 4 weeks, in the presence of febrile illness or immunodeficiency disorder, and any history of anaphylaxis to neomycin. How to avoid rubella? You just avoid exposure to rubella. Women must check rubella immunity status before becoming pregnant. Adherence to vaccination in postpartum if non-immune. Awareness and adherence to childhood immunization, and all children from 12 to 15 months and 4 to 6 years old must be vaccinated. And here are my reference pages, and thank you for listening and thank you for watching.